is on site. Band 2 is
Sorry.
You good?
Yeah, I saw that.
Is there histology on our exam?
I'm sorry.
Physiology is histology. So we have physiology this afternoon, but it's yeah, but like they're going over like cell forms and like.
Oh, yeah.
Through histology, we will learn physiology. Because he said yesterday.
I saw her. At the vet. Are you on riot recording?
Well, today we're talking about these three structures. We're not going to dissect the ear, other than maybe just hammering through a couple of them, just to see what we see. The ear is the middle and inner ear are very difficult to dissect. So we're going to review the ear here, because it's important, obviously important for physical exam. So you need to know some of the pieces of parts. What we're going to do in terms of the cranial vault is we're going to take off all 6 cranial skull caps. And then we'll remove all 6 brains. So we'll have plenty of study material. And we need to dissect into one orbit from inside the cranial vault. You don't go in through here, you go in through the top. It's very easy to do because the orbital plate is so thin. So that's what we're going to do today, okay? Let's get through the lecture first. This is another slide showing you what I mentioned yesterday. It's showing you sort of a better picture of it. If you're through the aponeurosis, the wound will gape like this in a coronal plane. If you're not through the aponeurosis, it won't gape in the coronal plane. So that's, everybody understand that? Okay. So when we take off the skull cap, when you look inside and remove the brain, the inside, the floor of the cranial vault is covered with dura. We'll go over that a little bit later on. If you remove all the dura and just look at the brain, the skull itself, these are the pieces and parts. The interior of the skull, or the floor of the skull, the base of the skull, is divided into 3 fossa, an anterior, middle, and a posterior cranial fossa. The anterior cranial fossa is up here, and it's made by, it's formed by a couple of bones. One of them is the frontal bone, the large frontal bone here. That yellow one in the middle is called the ethmoid bone. And then right here is the sphenoid bone. We mentioned this the other day. This would be the lesser wing of the sphenoid, the clinoid processes. So the anterior cranial fossa is composed really of those 3 bones. The middle cranial fossa is this portion here. Once you fall off this, or drop off this step, so the anterior cranial fossa goes down, and what you see here is the greater wing of the sphenoid. This is the middle cranial fossa, formed mostly by the sphenoid and the temporal bone. The temporal bone has different parts. We know about the squamous part out here, which is the thinnest part. We know about the zygomatic process of the temporal bone we looked at yesterday. And this portion right here is a ridge. This is called the petrous portion, P-E-T-R-O-U-S, petrous portion of the temporal bone. So you fall off the anterior cranial fossa, you're in a little valley here is the middle cranial fossa. You come up the petrous portion of the temporal bone, and you go way off into the posterior cranial fossa which consists of the temporal bone and the occipital bone. When you look at the flat bones of the skull, and that's what these are called, they're flat bones. It consists of two outer compact layers and a middle spongy layer. That arrangement, outer compact, inner compact, spongy layer, is called the diplobe. Up there, with the umlauts over the O. The umlauts over the O. All right. Any question about this? Very simple. If we look at the different contents of the cranial fossa, let's start with the anterior cranial fossa. The ethmoid bone, to say a bit about it, it has two distinct features. One is it has this protrusion that sticks up. That protrusion that sticks up is called the crista galli. It's a little spine that sticks up. Dura is going to attach to that spine. I'll mention that later on. On either side of the spine, there are holes in the ethmoid bone. It's called the cribriform plate. Not cribiform, but cribriform plate. And it's through those holes that you see in this amazing illustration here. The olfactory nerve is actually inside your nasal mucosa. It sends its axons through the holes in the cribriform plate to synapse in this structure called the olfactory bulb. They synapse in the olfactory bulb, and the impulses travel down the olfactory tract to enter the brain. Now, one of the complications of this arrangement is in deceleration injuries, when your head hits the dashboard or whatever, and you fracture your frontal bone, and it shifts everything back a millimeter or two, it can sever all of these tiny little axons going through the cribriform plate, and you can be anosmic. A-N-O-S-M-I-C. Anosmic. Means you can't smell. You can't smell at all. I've only encountered one case of that in my entire career, and that was some dumbass fell out of the back of a pickup truck, drunk down at Lake Texoma, and hit his head on the pavement. He was 20-something years old, and he could not smell at all. So it was pretty interesting. It's pretty interesting that he got drunk at Lake Murray. So drunk at Lake Murray, he got thrown off of Lake Murray. He and his friends were thrown out of Lake Murray. They wanted to continue partying, and they went to Lake Texoma. How do you get thrown out of Lake Murray? So, anyway, you know how?
No. What about people who are born with Meninges, though?
I've never known anybody like that. Do you know somebody?
Yeah, Martin, KOCO5.
Yeah, I don't know about that.
With an injury to the head like that, how do you, is it easy to test for smell? Like after they have all this like congestion and swelling and things, like how do you know with 100% certainty that that's what happened, or do you find out later?
No, it's pretty apparent pretty quick. We'll go into this as the year goes along, but taste and smell are intricately tied into each other, and you have a lot of problems with aging and the degeneration of the olfactory mucosa, along with taste buds. And so this guy, I didn't believe him. He came into the clinic for some other problem, you know, like an ankle sprain or something. I didn't believe him, so I went and got some coffee grounds and stuff. I tested sense of smell on him, and sure enough, he couldn't smell anything. And that's part of the physical exam that you'll do in testing cranial nerve 1.
Oh, you've answered my question.
Okay. So this was years before, where he had no sense of smell. Okay? The frontal lobes of the cerebral cortex rest in the anterior fossa. Oh, by the way, this right here is where you're going to go through to get to the orbit today. The orbital plate here. This is only maybe a millimeter thick. It's very thin, so it's easy to chip through in lab today. The middle cranial fossa is a little bit more complex. It has several features. One up here in the front is the superior orbital fissure. And then it has a foramen for the transmission of the optic nerve, called the optic canal. And then you have the three foramen that I mentioned yesterday, kind of in an arc. The foramen rotundum, foramen ovale, and foramen spinosum. And if you look at foramen spinosum, you can see these grooves that appear to be attached to it or coming out of it. Those grooves are for the middle meningeal artery that I mentioned yesterday. Over here on the medial side, here's the sella turcica, right? The hypophyseal fossa sits right there. On either side of the hypophyseal fossa, you're going to find two structures. One of them is the trigeminal ganglion, and the other is the cavernous sinus. I'll talk about here in a little bit. But there's another foramen right there. It's called foramen lacerum. Nothing runs all the way through foramen lacerum. In fact, foramen lacerum has a membrane across it, so nothing can. But, as you'll see here in just a little bit, there are several structures, three structures really. And it's called foramen lacerum, or lacerate serum, because of the jaggedness of the edges. One thing that you'll find there is that the internal carotid artery goes through like that. It enters, so foramen lacerum goes through the thickness of the base of the skull. It has three dimensions. It's not just a two-dimensional hole. It has three dimensions. The internal carotid artery comes up through the base of the skull and enters through the hole in the wall of foramen lacerum, and it comes out the top. So nothing goes all the way through foramen lacerum. And here's the petrous portion of the temporal bone right here. There's a groove on the top of that petrous portion. That groove that you see there is for a structure called the superior. You don't need to write this down because you're going to see it later on. Superior petrosal sinus. It's a venous structure that forms that groove on the top of the petrous portion of the temporal bone. The temporal lobes of the cerebral cortices rest in the middle cranial fossa. Okay? Remember what I said here about the squamous portion of the temporal bone being the thinnest part? You can appreciate that if you wind up with a blow to the side of the head here, and you have a fracture of the skull, and you've got this middle meningeal artery running right on the skull, it's pretty easy to lacerate the middle meningeal artery. And that's not a good thing to have an arterial bleed on the inside of your head, and I'll talk about that later on as well. But I want you to see how it fits there. Posterior cranial fossa, once we go over the top of the petrous portion of the temporal bone, there's a couple of holes here of foramen. One of them is the internal auditory meatus, or acoustic meatus. So you've got the external auditory meatus is out here. The internal is on the inside. So cranial nerves 7 and 8 travel through that hole right there.
internal acoustic meatus, is that what you said?
Acoustic or auditory meatus. There's another large structure right here called the jugular foramen. You see this depression right here? This groove? The groove ends in the jugular foramen. That groove is the location of other sinus structures. Back here, it's called the confluence of sinuses. This is the transverse sinus. That's the sigmoid sinus that ends in the jugular foramen. And what goes through that jugular foramen is the internal jugular vein. That's the start of the internal jugular vein from that sigmoid sinus. It's a continuation of it. Also, cranial nerves 9, 10, and 11 go through there. 9, 10, and 11 go through the jugular foramen. There's a small foramen right over here called the hypoglossal canal or hypoglossal foramen. Cranial nerve 12 goes through there. And then, of course, we have foramen magnum that transmits the spinal cord and the vertebral arteries. Okay? We're replacing all the lights on campus with LED lights, so it's a lot brighter around here. The cerebellar hemispheres rest in the posterior cranial fossa, not the occipital lobes of the cerebral cortex. It's the hemispheres of the cerebellum. If you flip the skull upside down, you should be able to see where these holes are from the bottom side as well. There's the jugular foramen. Right beside it is the opening of the carotid canal. So the opening of the carotid canal on this illustration would be right here. And then it communicates with foramen lacerum, like that. You should be able to see foramen ovale. Foramen rotundum should be able to be seen as well. Okay? Any questions about this? Pretty straightforward. One thing I didn't mention earlier, is probably on another slide, is the superior orbital fissure. What goes through the superior orbital fissure will be cranial nerves 3, 4, 6, V1, and the ophthalmic veins. What goes through the optic canal, or the optic foramen right here, will be V2. The optic nerve, the second cranial nerve, and the ophthalmic artery. So the artery enters the orbit through the canal. The veins drain the orbit through the superior orbital fissure. If you look at an MRI here, it shows the points I was trying to make earlier. There's the frontal lobe resting on the orbital plate. There's the temporal lobe. You have to look at this transverse section to see the temporal lobes resting within the middle cranial fossa. And then down here is the cerebellum in the posterior cranial fossa. All righty? There's a syndrome. Because the middle cranial fossa has the greater wing of the sphenoid, and it's that drop-off, so there's a bone in front of the temporal lobes, right? That's bony right there. There's a syndrome where a rapid deceleration of the head, and the brain keeps going forward, it squishes the temporal lobes. And there's an important nucleus right here in the temporal lobes. It's called the amygdala, A-M-Y-G-D-A-L-A. You might want to Google this weekend, because what I'm getting ready to tell you, you're going to think I'm making it up. bilateral destruction of the amygdala causes a syndrome called Kluver, K-L-U-V-E-R hyphen Bucy, B-U-C-Y, Kluver-Bucy syndrome. And that syndrome is characterized by a lot of behavioral changes. I mean, you act a little screwy, but the thing that makes this syndrome unique is you have an inability to suppress your desire to explore your entire environment in a sexual way, like with your mouth or with sexual motions, you know, pumping it. And it can be animate or inanimate objects, it doesn't matter. Like, ooh, that's a nice looking trash can right there. I'm not kidding with you. Kluver abuse. You Google it this weekend. I wouldn't talk. I'm not going to talk about that tomorrow at the white coat ceremony. Your parents. But it's because of that wall of the greater wing of the sphenoid is sitting in front of the temporal lobes, and it allows the temporal lobes to squish the amygdala because of the deceleration. So, Kluver-Bucy syndrome. Basilar skull fractures are not good things to have. These are usually due to significant force. You can see over here in this CT scan, there's a fracture up here. Down here, there's a fracture through the, this is the nasal cavity here. There's the orbital plate. It's actually a fracture through the junction of the ethmoid with the orbital plate, causing leakage of cerebrospinal fluid out the nose. So anytime you have a head injury and you have clear fluid coming out the nose or the ears, that's not a good thing. There are telltale signs of a basilar skull fracture. Ecchymosis, E-C-C-H-Y-M-O-S-I-S is bruising. Ecchymosis in the mastoid area is called battle sign. With basilar skull fractures, you also get raccoon eyes like this. This lady, those are real raccoon eyes right there. They look a lot alike. Blood from the trauma entering the middle ear will fill up the middle ear with blood, and you wind up, when you look at the tympanic membrane from the outside with your otoscope, what you see is blood behind the eardrum. So that's called hemotympanum. So those are characteristic features of basilar skull fracture. And if you have somebody in the emergency room that's been in trauma, or you have a head injury in a football field or whatever, you need to document. There's absent hemotympanum, absent battle sign, absent raccoon eyes. If you haven't figured out, when I say you have to document things, if you don't write it down, you didn't look at it and you didn't do it. So you have to document everything you see and do, or don't see. Okay? Any questions about that? Basilar skull fractures. I mean, you can't go in there and put pins and plates in basilar skull fractures. You have to let them heal for most part. Sometimes they can do some neurosurgeries on them, depending on where they are, depending on how severe they are. But most of the time, these folks, you just have to just put them in a hospital and watch them. Meninges of the brain. So we know that there's cerebrospinal fluid down there in the subarachnoid space in the spinal cord. How does it get there? Inside your cerebral cortices and brainstem, there are hollow areas called ventricles. There's a substance in the ventricles called choroid plexus. That choroid plexus synthesizes about 150 cc's of cerebrospinal fluid a day. The cerebrospinal fluid circulates through the ventricles. There are two lateral ventricles, as you see here, that communicate with a third ventricle that's in the midline, that communicates through a tiny little canal into the fourth ventricle, which is between the cerebellum and the brainstem. And then there are three holes in that fourth ventricle that allow the CSF to leave the ventricular system and enter the subarachnoid space. And that's how it gets out. Yep. You have two lateral ventricles that drain into a third ventricle. You have a third ventricle that drains through this tiny little canal that's called the cerebral aqueduct into the fourth ventricle. And there are three holes in that fourth ventricle where the fluid escapes into the subarachnoid space. So it bathes the brain and goes on and down into the spinal cord. You know, I was talking to you about little babies where you do a tap right here. The cistern you're headed for is right there. That's what you're trying to hit with the needle in a baby, doing a tap on them. Okay? Yes, ma'am.
Is the choroid plexus in the first ventricle?
It's in all of them. It's all of them, yeah. But it's not, it doesn't line the whole ventricle. There's a patch of it. Yeah, there's a patch of it. You see, this is the white, that light colored stuff. The roof of the fourth ventricle has some. The third ventricle doesn't have much in it. So, the thing is, though, you make 150 cc's a day, you got to get rid of 100 cc's a day, 150 cc's a day. You got to have equilibrium, otherwise you're going to wind up with increased pressure. So the way you get rid of it is in certain areas of the meninges. And if we look up here, let's go over the meninges. Here's the dura right here, outermost covering, right? The red layer is the arachnoid. And then you see the little arachnoid fibers attaching it to the yellow pia. The pia forms the outermost covering of the brain. Now, in the brain, when we take the dura off, you'll see that the arachnoid covers the outside of the brain. The arachnoid and pia do not go down into the gyri. It's only the pia that does. So you'll be able to see the arachnoid covering really well on the brains we take out today. The dura does a weird thing in certain parts of the inside of the skull. It splits. And you see it right there, splitting. It forms two different parts. There's a part that sticks with the bone, and then there's a part that goes with the brain. You see that? The two parts that go with the brain will eventually fuse into a sheet. That sheet is called a falx. Up in the cortex, it's called, between the two hemispheres, it's called the falx cerebri. Now, the space where it has split is a sinus. It's called a sinus. I'll go over all the sinuses here in a minute, but it's a sinus. That's where venous blood goes. You don't have veins draining, going into bigger veins and draining into the internal jugular. No, the veins of the brain drain into the sinuses, like you see here. It's the sinuses that drain into the internal jugular. Now, in certain parts of the sinus, there's a sinus right here in the middle of your, the sagittal, right here in the middle of your skull, right up underneath your skull. It's called the superior sagittal sinus. I think that's what this is, superior sagittal sinus. Where it's split here, some of the arachnoid pierces that split, that neural dura, and forms these little things, these little mushroom-looking things called arachnoid granulations. Now remember that this is the subarachnoid space right here, right? Cerebrospinal fluid crosses those arachnoid granulations to re-enter the venous circulation in the superior sagittal sinus. That's how you get rid of it, through the arachnoid granulations.
So CSF goes into the superior sagittal sinus through that arachnoid granulation?
Yes, sir.
And the sinus drains into the ventricle.
Sinus drains in, no, sinus doesn't drain into the ventricle. Sinus drains into the internal jugular vein.
Oh,
Yeah. Everybody understand that? Okay. So you can see in this illustration here, Ryan, well, everybody, not just Ryan, the CSF is produced here, it circulates around everything, and then re-enters the venous circulation through the arachnoid granulations. These arachnoid granulations in older individuals calcify, so you can touch them today and you can feel that they're hard. You know, they're kind of cool. And they look like little cauliflowers. DM.
Does serial pump spinal fluid like have a pattern of how it travels, or does it just kind of go out there?
It just circulates, yeah. I mean, I'm sure it probably has a lot to do with gravity, motion of your head. If you, for any reason, if you block the CSF from leaving the ventricles, then you wind up having the ventricles swell, and that's called hydrocephalus. Spina bifida is different. Spina bifida involves down here in the spinal cord. It doesn't circulate for some reason properly. I don't know why spina bifida kids have hydrocephalus. But what they do to get rid of that increased pressure, and if you have a tumor or something, especially right here in this part of the cerebellum or brainstem, that little cerebral aqueduct is tiny, like a pencil lead, tiny. The most common place for blockage is right there. But what you do is you go in here, you stick a port inside the ventricle, run it outside the brain, down through the subcutaneous tissue and into your chest or into your abdomen, and let CSF fluid leak into your chest or abdomen where it just gets absorbed. But I don't really know why in spina bifida kids, meningomyelocele kids, but they always have a shunt, always. I've never known one not to have that. Probably shouldn't say always, but I've never known one not to have it. You can have tumors of the meninges. This is called a meningioma. A lot of times people, when they say they have brain cancer, it's not really brain cancer, it's a tumor of the meninges. The meningioma is benign. However, if it occurs in a place that you can get to it, you can remove it for cure. If it occurs in a piece of meninges that's in a bad place, you may not be able to remove it. So it's inoperable. It's just bad luck if you get one of these in a place like that. There are several central nervous systems. There are several tumors of the brain that we'll talk about this year. But a meningioma, remember, is the meninges, not the brain. Okay, so, we talked about that falx cerebri right there. if we look at the system, this is the falx cerebri. It's a pretty big sheet. You're going to see today, it's pretty wide. It's impressive. Now it's open in the bottom because that large structure right there called the corpus callosum is the huge bundle of fibers that connects the right hemisphere to the left. So both sides of your brain can talk to each other. That's why the falx cerebri is open in the middle, or inferiorly. There's also a falx cerebelli down here. And then there's another fold created by the same sinus structure that we talked about. This separates the cerebellum from the cerebral cortices called the tentorium cerebelli. Tentorium cerebelli. I'll show it to you in another slide.
Separates the cerebellum from.
The occipital lobes of the cerebral cortex. One point that I want to make sure on this slide is that when you're dealing with subdural hematomas, a subdural hematoma is when the dura that you see here splits. A subdural hematoma occurs in split dura, not the sinuses, but the dura will split in other places. So you'll have, if you're looking at hematomas, if you have a hematoma here, it's epidural. If you have a hematoma here, it's subdural. If you have a hematoma here, it's subdural. This would be the arachnoid, like that, okay? Epidural, subdural. Notice that neither one of those is in the subarachnoid space. So if you did a spinal tap, you would not see blood in the cerebrospinal fluid that you withdrew. In an epidural or subdural hematoma, you don't get blood in a lumbar puncture. It's only in a subarachnoid bleed will you get blood on a spinal tap. Here's a better picture of the tentorium cerebelli. There's the falx cerebri. The falx cerebelli is down there in the posterior fossa, and there's the tentorium right there. The tentorium has an opening here that transmits the brainstem. And that opening is pretty small. It's about, it's a little bit bigger than a quarter. It's pretty small. When you have increased intracranial pressure, you can get a lot of things herniate through that opening that are not good. All right, so let's talk about the sinuses. If these two falx and one tentorium are there, there must be a whole network of sinuses. And yes, there are. Here's the superior sagittal sinus that runs at the top of the falx cerebri. There's an inferior sagittal sinus that runs at the free margin. There's a deep vein here called the vein of Galen, G-A-L-E-N. This one right here. That drains deep brain structures. The vein of Galen and the inferior sagittal sinus drain into this structure here called the straight sinus. The straight sinus is located, so you've got the falx cerebri and the tentorium here. The straight sinus is right there at it runs along that junction. So the straight sinus and the superior sagittal sinus end right here in the confluence of sinuses, where they all come together, the confluence of sinuses. I'll go over more detail here in just a second, what happens from there. Let's talk about a bump on the head. This is a skull fracture here. You can see skull fractures show up best on CT, not MRI. So there's a skull fracture there. On this illustration over here, you see the swelling externally. So this would be a hematoma outside the big goose egg out here. But inside, we have a hematoma formed right here. Now, because your head is a ring, it's a solid ring, because your pelvis is a ring, because your vertebral arch from your body up to pedicle, lamina, pedicle is a ring. Bones are rigid. If you break one side of the ring, almost always there'll be a break on the other side of the ring. In the case of the skull, if you get hit here, the shock wave goes through the soft tissues of your brain and will impact over here as well. So you have a fracture over here, a fracture over there, a hematoma over here, a hematoma over there. This is called, in this guy right here, this is a separate brain picture from that one. This one was hit right here. So this is called the COUP, C-O-U-P, hematoma. And the COUP on the opposite side is called contra-COUP. So when you're describing this, you would say this is a COUP, contra-COUP lesion. Yes, ma'am.
How do you know which side it came from? Because from the outside? I mean, if you saw
Yeah,
the image.
I would just, I mean, you would know that from the patient's record.
Okay, but not from
Yeah,
the image.
not necessarily from here, but if I saw that, I would say you got hit there.
Okay.
Is it swollen on the
Yeah,
initial?
yeah. So anytime you have an injury on one side that transmits to cause an injury on the other, whether it be the pelvis or the brain, that's a COUP, contra-COUP type lesion. Okay. This one happens to be epidural. So the epidural hematoma, because we're in the temporal lobe here, most likely to injure what artery? Middle meningeal, right, middle meningeal. And middle meningeal bleeds. You have about a window of about 2 hours. Does it say middle meningeal up there somewhere? Okay. You have about 2 hours. Well, there was some grinning going on right here, and I thought, okay, well, it probably says that up there. You have about 2 hours to repair it, or they're going to die from the increased intracranial pressure. 2 hours is about it.
To drain it, you said?
I'm sorry?
What's the intervention that you do?
No, an arterial bleed. You have about 2 hours to fix it.
Fix it.
To open them up, find the bleed, and clamp it off. In that previous slide where it said most subdural hematomas are venous, you have a lot longer window to fix them. Here's some examples of epidural versus subdural. Epidural is completely separated dura from the underlining, from the underside of the bone. In this one right here, the dura has split, so you've got it below the dura. It's not, again, it's not in the subarachnoid space. In this illustration here, we've opened up the superior sagittal sinus to reveal the arachnoid granulations. In some areas, though, of the superior sagittal sinus, there are connections to these little pools of venous blood. They're called lacuna. So they're connected, so the veins are draining into the lacuna, which drains into the superior sagittal sinus. These lacuna invariably are filled with these arachnoid granulations. Matter of fact, the arachnoid granulations are so prominent. If you look on the skull cap, you can see impressions of the superior sagittal sinus and the little arachnoid granulations in the skull cap. You'll see that today. This is the middle meningeal artery right here. It runs between the skull and the dura mater. Your migraine headache is most of the time due to that artery. Here's an illustration of the sinuses. So we're left here at the confluence of sinus. Right? We've got the superior sagittal sinus, the inferior sagittal sinus. There's the great vein of Galen. Galen was an anatomist that lived in the 2nd century, in case you're on Jeopardy. There's the straight sinus. There's the confluence. Now you got to get the blood out of the confluence into the internal jugular vein. So that's why you go out the transverse sinuses. You see there's one that goes either direction. It wraps around here, transverse sinus. And in that sigmoid sinus, the sigmoid is S-shaped. It's very apparent on the skulls. Sigmoid sinus, and right there would be the start of your internal jugular vein. Remember how we talked yesterday about, about picking zits here, and that infection can travel inside into the cavernous sinus, I said? Here's your facial vein out here, communicates through the ophthalmic veins, there's a superior and inferior. They drain into the cavernous sinus. The cavernous sinus, there's one on either side of the sella turcica that said the two things were there, cavernous sinus and the trigeminal ganglion. The cavernous sinus drains through the superior petrosal sinus. That's the thing that's at the top of the ridge of the petrous portion of the temporal bone I mentioned earlier. And then there's an inferior petrosal sinus that drains into the, well, let's put it this way. If your transverse sinus, sigmoid sinus, there's the internal, there's the jugular foramen. So this would be the internal jugular vein. The superior petrosal sinus drains there at the junction of the transverse and sigmoid sinus. The inferior petrosal sinus drains at the junction of the sigmoid sinus and internal jugular vein. The real take-home message that I want you to get. So here the superior and inferior ophthalmic veins is the direction of blood flow is that. If we follow this on around, here's the confluence of sinuses. The direction of blood flow is towards that. Okay? The arterial supply of the brain, again, we know of 4 arteries, the internal carotids and the vertebrals. These 4 arteries eventually join each other. Here's the internal carotid going through the carotid canal, passing through foramen lacerum. You see that? There's the bottom of foramen lacerum there. And once it enters the cranial vault, it makes an S-turn. It makes an S-turn. You see it going up and then forward and then back. One of the first branches off of the internal carotid is the ophthalmic artery right there. the ophthalmic artery. You find this, there's the hypophyseal fossa right here. You find this right there. There's the hypophyseal fossa. There's the cut internal carotid right there. It's inside the cavernous sinus. Another thing that's inside the cavernous sinus are cranial nerves V1 and V2, 3, 4, and 6. All of those structures are within the lateral wall of the cavernous sinus, except one. That's cranial nerve 6. The abducens nerve actually travels through the cavernous sinus, and it just floats through there. Remember we talked about picking the zits, and I said you get infection, you go back up through into the cavernous sinus? What do you think that infection is going to impact? It's going to impact cranial nerve 6. Cranial nerve 6. You see right here, this is a gooed up cavernous sinus. Cranial nerve 6 has one function. It goes to an extraocular eye muscle called the lateral rectus. Turns the eyeball laterally. If you damage cranial nerve 6, what's going to happen to that eyeball? It's going to be unopposed medially, and it's going to point inwards, like this guy right here. So if anybody comes into your clinic with a big old erysipelas thing going on right here and a medially deviated eyeball, you better send them for an MRI, infectious disease, ophthalmology. You better get them out of your clinic.
Is cranial nerve 6 why some people are born with like an eye that turns inward? Or is that related to the
It's not
muscle?
cranial nerve 6 that's the problem, is how tight the muscle is.
Oh, okay.
You fix the problem, you know, like strabismus is cross-eye.
Yeah.
You fix that by dealing with the muscle, not the nerve, right?
So 6 was the only one impacted, even though they're all within the cavernous sinus.
Well-
But one isn't on the lateral wall, one goes directly through. Is that the reason? Or what?
Right.
Okay.
The 6 travels within the blood. All of the other ones are embedded within the dura of the lateral wall, so the infection can't get to them as easily.
So it literally just is in the blood supply? That nerve is in the blood supply there?
Well, the nerve is still surrounded by meninges, the nerve itself is,
Okay,
but it's floating in there. It's surrounded by blood,
got it.
and it's easier to attack.
The others are against the wall, so they're a little more protected,
They're embedded within the wall.
embedded.
They would be like, you know, here's the inside of the cavernous sinus. Those other nerves are on the other side. They're in the wall itself. I can't get to them.
Okay, what's the material that embeds them in the wall?
It's just part of the dura.
Just part of the dura?
Yeah. Yep. Okay. Why don't we take a break here, and then we'll come back.
Yeah, and that in the morning is not a great idea. Gotta go blow my nose. Can you run me through 5 minutes of yoga? Oh,
I'm looking at my shirt, girl.
I moved. Yeah,
You do a couple of sun salutations.
you look so comfortable.
I always like this. Like, I'm such a freaking weirdo. If you look back here, I'll be like this. Sometimes I'll like literally have like one of my legs up on the desk, like that. Circle of dances. Oh my god.
My dad would do this all the time at work. Stroke patients, and my mom's like, I have to get that. I'm back after.
Lunchtime yoga, sunrise yoga, just
Child's pose followed by a nap?
yeah, just
I could probably,
just 30 minutes of shots.
I'd probably fall asleep in child's pose if I
I was like,
Have you
seen how many slides we have? Like, how are we gonna decide this?
I bet we have to go out to histology.
That's what I was thinking.
There's no way we're gonna get through it.
It's already 9 and we're still like doing these slides.
where there's a neon t-shirt.
I mean, I'm pretty sure you just cancel one.
Yeah, we need that.
I'm like, I literally got these out of my clean country.
I didn't go anywhere this summer. I have regrets.
I wanted to go somewhere.
My life had not been this scary, and like, look at this.
Plus,
Like, I can grade it. I have 0 qualms.
Yeah, it was a little bit though.
Tough last night, went to go like out of view.
I know. That's where I want to go for a break. If I had to go, I could start. Like this spring break.
When I actually have to shave.
I want to go. I have to. I have to get out of here. I like to go back. Yeah, that's
Which is good for us.
You know where Stacy, she's
so once before they like
Is it?
it ends in like 2004.
Yeah. Lacey likes it best. And she always goes to
Huh?
Good luck, everyone. I don't think it's on. Is it not? It's flashing red. Is it? Yeah, it's so on. Actually, yeah, it might be. You can do this. I promise.
In my
Give myself some motivation.
right new water.
stand up like
Really very well.
I don't want to go back there.
I went to Meninges. I don't feel like I could go through it.
Oh.
I didn't want to go like come down to it. Mine's right here. So I feel like on the bed, you guys don't have to get hard. And actually, I would really like to see everything. Yeah.
Yeah, well, oh my gosh, this is my favorite thing.
I wish mine, because I had a bird one I can go today. I wish it was bigger though.
Like, she's like, when I get hot and I get tired. I get tired by just soul. I feel like I'm sitting there and I'm like, I'm telling you, it's like I'm like hibernating.
Yeah.
Yeah, I don't even remember what. It's just like they always fucking
Not sleep outside. No, I wish I could. Like I feel like, oh, now I can go to bed.
Now I'm super tired.
Send it now. Send it now. It's appropriate.
But this is all reserved. After 3:30, there's no more new material. I guess mine.
Oh, the t-shirt?
On the bottom ones that don't have anything,
You can get an embroidered.
okay, you put